So welcome everybody. Thanks for inviting me. Thanks for the kind invitation, especially to Lewis, who convinced me to do this. And let's go. So the role of public health in society, economics, and politics. That's a title provided, I must make that very clear, provided by the organization. And it's a highly ambitious title, so it's quite confusing what to talk about. There's so much here. Rather than giving an introduction into what public health is and what epidemiology is, I thought I'll give 10 selected examples of public health topics and discuss for each of them aspects or selected aspects of society, economics, politics, and implications. So what I thought is 10 topics with relevance, 10 topics personally selected. The focus is also on success and future challenges for public health. My goal is to talk about 3 minutes for each slide. I don't know if that's realistic. I'll try to time it a bit so that leaves ample time for discussion in the end. If that works, we'll start. So it is a pretentious title, but that should be the fun of today, giving you an overview. I started with the classic foundation of modern epidemiology. It's 1854, and it started with infectious diseases, and that's why it comes from epidemiology. But really, it's not about fighting epidemics of infectious diseases, it's about quantitative thinking. And that is illustrated here with 2 slides. And just to show you how powerful it was, 1845 was a time of cholera in London. And there was a man called John Snow who did something which was unusual for his time. He mapped the cholera cases on the map of the inner city of London. And you see that above. So each death of cholera was a black spot. And he noticed a pattern occurring in that city. And he also noticed that that pattern was related to what you see below, the distribution of drinking water. Essentially, if you wish, the wells or where the water supply came from. And thus he could conclude that it was an infectious disease spread by infected drinking water. That was a major breakthrough because it meant you could close that pump, you could close the Broad Street pump, which was the one that was infected, and you could fight this infection and reduce cholera. It was the most effective reduction of cholera. So it was not by infectious agents or not by antibiotics. It was done by understanding the source of the problem and addressing that with quantitative thinking. So it's really the big success, and we would wish we were always that successful in fighting epidemics. Now, I want to tie this to COVID 2019. So after many years of being quite silent with pandemics in at least the high-income world, all of a sudden in 2019 onwards, we saw the well-known epidemic. And one of the questions we could ask ourselves is epidemiology and public health still successful? And you know, there is no agreement on that. Many people will have learned the word epidemiology only by that epidemic. They've never heard of it. You might not have heard ever, but all of a sudden you could, people that never, you know, my mother could never pronounce the word, what I do, but all of a sudden she could. So what could we think of if we discuss, was it successful? I am of the opinion it was incredibly successful. I'll give you a few indicators of why I think it was so successful. In March 2019, early March, late February, I was in Boston and decided to leave Boston because of the pandemic and the shutdown that was coming. It was not coming then, it was just predicted, and the spread. And I went to the colleagues in infectious disease epidemiology, and they gave me a prediction for the summer. They made a curve of the deaths, they made a curve of the spread, and they said, if you go take clothes for 6 months, take your summer clothes, it will spread. And this curve actually came as predicted, also because of the slow and lacking lockdown. So infectious disease epidemiology has been, and there's no doubt about that, extremely successful in modeling different scenarios and with all uncertainty of such, predicting it. We've been extremely successful in calculating the mortality estimates, been extremely successful in testing the effect of vaccinations and the safety monitoring. We showed that there's very little problems with safety, and we showed. So despite, it's a very sad message because we've all been impacted economically by COVID. I think by and large, and that's up for debate, epidemiology showed its strongest kind in prediction, in finding ways to treat it, in recommending mask and ventilation. And some of these were debated and changed and altered with more insights, but it was incredible to see, how well they predicted mortality. So I think that's one of the successes, old-fashioned infectious disease epidemiology. Let's go to another topic, cardiovascular diseases. Arguably, cardiovascular diseases next to cancer are the main killer of our times. You will know that 1 in 4 people or more die from cardiovascular disease. So, if you don't die from cancer, cardiovascular disease, the rest is much less common. It's, perhaps a bit of neurological, but that's what is the big killer. I want to just introduce you another success of, and again, with implications of that, of epidemiology / public health. It's the Framingham Heart Study. Framingham is a small study, just a few 10,000 people next to Boston, actually, here in Massachusetts, where in 1948, the United States, so not a university, but the United States Public Health Service started a study in 5,000 persons. Here is a very old slide from 30 to 52 years and followed them over time. But what they did measure is they measured blood pressure and cholesterol. And from that one study, and many successors, many similar studies, many countries around the world have done it, we have learned that these are the biggest treatable risk factors of cardiovascular disease. Just imagine in 48 it started, 10 years later, 20 years later, we learned from this study that high blood pressure, high cholesterol is really bad. And now we have treatment for both. We have treatment for both. And what do we see? And that is amazing. You may not know that the risk of dying of stroke, which is, blood pressure is intensely tied, high blood pressure to stroke, has gone down over the years. So if you see the small graph, you see different stroke is in blue, it's gone down since, many, many years. Cardiovascular, we had a peak in the 1960s, 70s, partly related to smoking, but since it's gone down. So what you must realize is we are getting older because of this study. That's a public health, it's a massive, massive, massive breakthrough that we have treated blood pressure. So if my age group, about 25% to 30% are treated for high blood pressure. They are screened for high blood pressure and they are treated successfully, and that prolongs life, healthy life and life itself. So that undoubtedly is, so we now see that cardiovascular, it's not a disease of the past, there's still a lot of myocardial infarctions, but there is prevention. And I must also say there is successful treatment of myocardial infarction, which is much more a medical success. So if you have a myocardial infarction, whereas 1/3 of the people would die, today only 1/3 die. So you can easily live 10, 15 years after a myocardial infarction. That's another big achievement. So here, public health and medicine go together. Let's go to topic number 3, which is one of my interests, mental health. Didn't really know what to talk about. You can talk about stigma, prevention, screening, and treatment. I wish to talk about everything a bit, so let's rush through this again. Just to give you an overview, it's another big field of public health, but public mental health. It's fascinating to see that, for example, stigma, which was massive in my mother's generation, is reduced in mine. It is still present, as you can see in this slide. Most people agree that many people think that people with mental health are dangerous, which essentially is a clear prejudice and ill-founded. They are not. They are by and large not, despite an incidental shooting of somebody who has acclaimed mental health. Largely, and not only largely, on a population level, people with mental health are not more dangerous. So there is stigma, but we can show that one of the big successes of your and my generation is the destigmatization of mental health. Politicians speak about their eating disorders, about their depression, about their alcohol problem. We are much more open. You can come back to the job. Most of our, not so much violence, not so much, but many of the depression and others are largely, the stigma is going down. That's a societal success. Let's talk about two other things very briefly: prevention and screening. You know, you would want to, we talked about the success of prevention and early treatment of blood pressure. I can tell you that for mental health, that's been much less successful. So we had put lots of money in screening for eating disorders or early symptoms of psychosis. That's really severe mental health if you have hallucinations or so. We put money in Germany too in early language and autism screening. And by and large, we must conclude that has not worked well. We do not identify the right people. We don't have the treatment. Earlier treatment does not help enough. What we do somewhat better is prevention. So rather than finding the early onset very well, we can prevent it on a more broad level. We've been quite successful in preventing suicide from very simple measures in sort of having safer balconies or whatever. And bullying in classroom is a big success. Very good programs exist to prevent bullying in classrooms. So, you know, that's something a school should really do. And the same goes for alcohol. And then the last thing I want to touch on this mental health is the time trend. This is a publication from somebody from Columbia University who published and showed that really depression didn't go up, but we think in the last years there is evidence, and that is becoming even stronger through the COVID period, which is not depicted here. There is some evidence that mental health problems are on the rise. If you just focus in on adolescence, depression is going on the rise. But actually, interestingly, I want to point out that adolescent aggression, so rule-breaking behavior, so those boys that, often boys that skip school or very, very aggressive conduct problems, that is going down. So the gang boys that do sort of very naughty things, that's going down. Probably they're playing computer games. And some people have said it's essentially a feminization of adolescence, that we have much more pressure on school and doing things in organized ways and rule-based. So we see less of the rule breaking and somewhat more of depression. That's an interesting topic, how that develops over time for public health. And there is many opinions, as there are many people studying it. I'd like to go to something. Now I've told you some successes. Not everything that public health addresses becomes a success. So we should go to topics which are disasters, and where essentially you could argue public health does not know what to do, or public health knows what to do, but nobody listens. And that one of those examples are weapons. So private weapons, we're talking about private weapons. So we're not talking about police weapons so much. I'm talking about military weapons, talking about private weapons. So there's been lots of studies relating weapons to suicide primarily. It's really suicide, one of the big things that kills, and homicide. And don't think of shootings in first instance. Think of the husband killing the wife, or the wife killing the husband, one-on-one homicides or drug violence. That's what's happening. And there has been very good studies, not only from the US, but even from a small country like Switzerland, which has a very high rate of weapons, that you see because of the many weapons in Switzerland. You don't see anything near the US, but you do see a small increase if you compare it with a country like Austria, where there's not nearly as many weapons in private ownership. So we know that guns kill, and it's suicide and homicides. And it is a huge topic of domestic violence. As I said, that's where it is. It is, of course, very spectacular mass shootings, which bad enough, but population-wise, not even that many, is the domestic violence much bigger. We also forget that you not only die because many people have long wounds. So for every person that dies, there are probably 3, 4, 5, 6, 7 which are wounded and have long-lasting injuries. Then there is a spatial pattern in some regions. It's much more common than elsewhere. There are lots of costs. So this is, if you think that it's talking about economy, the violence is really very costly. So all that weapon ownership in the US is not really a good, I would say it's highly inefficient in all ways. and suicide I mentioned. And think of even pediatric suicide, something which is very rare. You know, if you're under 18, people that kill themselves under 18 is a very rare and very sad and very dramatic event. But weapons make that much more common. And the other thing I want to touch, well, I'm not talking much about race, but police, gun ownership, and race is another obviously hot topic. You've all heard of Floyd, George, and the many other cases. And just to look at the statistics, so I'm not sure I have to move my gallery here, my view, but see if you take the motor vehicles with the introduction of safer vehicles, but also safety belts, we see a decline, 60% decline. That's quite dramatic, you know, that's very good. And actually the traffic has gone up. So although there's much more traffic now, this has gone down. Whereas for, you know, this is whatever it is, there has been perhaps a tiny bit decrease here, but otherwise it's really a straight line. So weapons, we have not made excess. And although we have very good evidence, it's a bit of a frustrating topic for my colleagues to study. For 30 years, we know what to do, just reduce ownership, but nobody is listening. Let me go to the next slide. I think that's the next slide. So I want to talk about something which seems to be out of the realm of public health. And I do see that is wrong, because I think this is a public health study and it is a public health message, and it is indeed a public health group. So there was a Nobel Prize. There's never been a Nobel Prize for epidemiology ever in medicine, but there has been a Nobel Prize for pedagogic work, if you wish, and that has been given by economists. It's been given to Hackman, a Chicago-based economist, who did a study of and called the Perry Preschool Project, the PPP, the Perry Preschool Project. What he did is he went to the poorest areas of Chicago. He randomized the children or the schools. So he said, this school gets this intervention, this school doesn't get the intervention. And then he essentially did very organized sort of daycare and in particular homework and social support. So he sent a team of community nurses, many of them Black, but here's a white one, to this largely Black population and offered them the optimal preschool programs. He said, I'll give you a top program. And they even structured the daily life, because I spoke once personally to one of these, this is many years ago, it started in the 70s, I think. They came and sat at the home table, you know, to organize the families and to have meals and to do the homework with the children. They taught it. And what they saw is that the children, from when they grew up, when they're now long-time adults and, you know, even in their 40s, 50s, in many aspects, they were better off. Not so much in IQ, but very much in school and academic performance, and that related to income in a big, big, big scale. So here you see sort of the income curve. So everybody earns more income by age, but those who were treated, those who were randomly assigned this intervention. So just by luck, these kids got the intervention and they did earn significantly more later. And it is an economic study in all due respect, because the outcomes were, you know, they were not so much happiness, it was school and academic and job achievement. And he showed and he modeled later that if you do the intervention in the earliest years, the effect for every buck you spend, for every dollar you spend, are bigger than if you spend it later. So this was a game changer in saying early economic intervention in the poor pays off largely if you do it early. Don't wait, start at this age. Again, it's a Nobel Prize winning study just because it made it so, you know, it's been hard to replicate in the sense that it's such an intensive study. It's hard to upscale this study, but it's been very impressive for all of us, phenomenally impressive to see, and rightly deserve that Nobel Prize. We should invest in early education. So if you ever fought for school, you know, better schools and social programs going with schools, so homework programs and organizing people to, you know, get to good schools, that is really being shown to work. After that big success of, I would call it public health, but you can call it, you know, economy if you wish. We'll go to something which has been a disaster. Now, I would say not disaster, but very hard. So what we would like to do as epidemiologists and public health people is tell people how long they live. And I'm illustrating that with two things, that approach. So we would like to measure genes, we would like to measure blood pressure, we would like to measure whatever you measure, you know, whether you had a kidney disease, whether you're treated, whether you're healthy, whether you're happy, all these factors, we can measure hundreds of factors and try to model them so as to predict how long you live. So in other words, take me, I'm just above 50, you know, how long do I live? You can measure, you know, my blood pressure, you can measure my kidney function, you can measure my lung function, you can measure my cognitive abilities, you can measure, you name it. You can measure whether I'm, you know, discriminated, you can measure my income, you can measure all these things and then try to predict, will I live another, you know, at my age, I'd probably live to, statistically now, I believe 87. So you could say, you know, am I somebody who makes it to 93 or are my chances high to only make it to 79? That exact question is of big economic, measure an insurance company or whatever, value. But however, we're actually quite bad. I'm illustrating that in one funny way because there's a famous talk on embracing randomness in public health and research and practice from a guy called George Davies Smith, who illustrated it as we can't hardly see that it was a 100-year-old woman who uses her cigarette to lighten the fire of these numbers on her 100th birthday cake because she's been smoking for 93 years. And what else would she do than continue smoking on her 100th birthday? And, you know, it made the news. Life takes a long time. The idea of George Davies Smith was to present the evidence that really much of human biology is very random. It's a philosophically interesting thing that our processes in our body, what we experience is how our blood pressure, you know, interacts with other things. It has a strong randomness component and it cannot be predicted by our causal modeling or predictive modeling. That is something which is humbling, which means that our predictive values are poor. And what I'm trying to say here is a study that I did with a student many years ago, but it was still the study that uses nearly the most risk factors, more than 100 or 150 risk factors to show, this is a prediction line, and this line, which is quite a good prediction, but it's simply age and sex. So if you know my age, if you know my sex, then you can predict reasonably how old I will be. Everything else, all that other even genetic information contributes very little. It doesn't push up that prediction line. And the longer we go, the worse the prediction is. So if you follow me 10 years up, it will be even harder to predict whether I'm still alive. In other words, you can, of course, if I have very high blood pressure, of course, if I have kidney function problems, of course, if I have lung problems, that is not good for my life expectancy. True, but that said, the exact chances of me dying, it's a group level thing, but myself, this one individual, Henning Tiemeier, is very hard to predict. Okay, we'll go to the next one. We'll have to rush through it. We're nearly there. I want to show you arguably one of the biggest successes in public health. It's a real public health, and it's got to be mentioned. And that is the reduction in maternal mortality ratio. And that alone, if you want to ask me what is one of the most impressive things they've done, perhaps it's the cardiovascular health, but really I think the world is a much better place than in the past. I really endorse that, given all these other things that are happening. You know, you can talk to me a long time, but it is a much better health because mothers and children are at so much better health. They're not dying anymore that much as they did in the past. If you take a country like Sweden, in several years, we went from 900 women of 100,000 births were dying. 900 of 100,000 were dying. We are now down to 8 in that country. That is incredibly much safer to have a child than 3-4 generations ago. It's unbelievable, this success, and it really is phenomenal public health success, partly medical, but largely public health. And you know, if everybody says it was so wonderful in the 1850s or 1860s, well, you know, these things were terrible. And to remind you, Sierra Leone has not come much down. You know, there's still countries around and much of sub-Saharan Africa is above 150 and around. So that's it. And if you look at infant, neonatal, post-neonatal death, it is the same. It's collapsed. It's gone down immensely. Whereas 10% would die, we now are essentially below 1%. This is more than one magnitude. So, if you take public health, I want to argue to you as a take home, the world is a much better place because of public health, because of maternal and child mortality, and because of our life expectancy, which I'm not talking about, but it's also a great, great success. Let me move on to something else, which is very public healthy. You might already lose interest or overview of all these topics, but bear with me, it's not much to go. Nutrition. So I think nutrition is one of the most cited. If you publish on nutrition, you're always in the public media. So the Bild Zeitung or wherever will say, eating nuts makes you live longer, and this will make you make you sexy, and this will make your skin better, and you eat, and you'll be happy, beautiful, and strong and successful if you just eat the right stuff. Nothing is less true. So I think it's just full of rumors, and we had to correct it, and we knew that eggs were bad and now they're good again, and we can eat eggs, and we got it all wrong. But there are a few things that we didn't get wrong that are here to stay. Let me focus on those. 3 exciting things, I think. The Harvard School of Public Health is famous for its work on soft drinks, showing that in particular, energy drinks, sport drinks, some fruit drinks, but in particular Coca-Cola-like drinks, the sodas, are really killing people. There's no other way. They're killing people. Drink much of that, you'll be fat, you'll have a metabolic problem, and you will have diabetes, and you lose years of your life. It's really the big problem. And the success here is immense. We now have schools that do not sell it anymore. And even, there's some problems with other drinks, but the best thing is drink. Well, I'm not so sure about the skimmed milk. Milk is good, seltzer water, that's what you should drink. Some of that, but none of that. And that's been shown so clearly. Just stay away. Another thing is allergies. There has been a game changer a few years back. We have a lot of allergies, and some people say you should not eat, or you should eat early in your life. Should you eat things that you might be allergic to early in your life? And then there was a trial. So they randomized people at high risk of peanut allergy, so peanut allergy, and they I call it the peanut butter trial, but it's really the peanut trial, eating trial. And they showed that with early exposure, so if you give a kid very early, before the first year, perhaps even before 9 months, if you give them peanuts, they will not develop an allergy ever. This is absolutely foolproof. So rather than avoiding things, give it to them, give them variation, give them the trials, and you can avoid allergies. It's a brilliant trial because it was so conclusive. Rarely have we seen a trial with hundreds of people where in the group that has the early intervention, that eats peanut butter early, we see no allergies, not a single one. Can you imagine that? That's a trial which was phenomenal. It was so mechanistic, biological. It was just great. And then the other great trial, which comes actually largely from Spain, where they did wonderful work, is, if you change your diet to more vegetables, to more legumes, to more fish and oil and other things, and actually also enjoy meals with others, which was part of the trial too, because they gave them presents, you can live longer. So, if you're not into sports, physical exercise, eating Mediterranean diet may be an easy bet for you. Okay, we'll continue. We have 2 more topics and then it's done. So forgive me for the time. I want to talk a bit about global health. So that means for low income and middle income countries. And here I think we've made so many mistakes. So many things went wrong, but at the same time, so many things don't work, but at the same time, there are also successes. And I want to give you a very simple success, which is called kangaroo care. So if you're born as a preterm, very premature child in sub-Saharan Africa or India, then chances that you survive are much smaller than in the West. But they can be incredibly increased, really incredibly increased by a very, very simple measure shown in trials and observational studies, which is called kangaroo care. So if the mother is taught to put it on her breasts, essentially, she warms, and the child, for many reasons, because of the attachment, because of the warmth, because of the temperature regulation, survives much better. And here you see to what extreme you can take it. If you have several children, it really helps them survive. A simple measure, but it's hard to, to teach that again, because it seems so counterintuitive. And that is, of course, if you have no incubators, which are not really, often not even that much better. I want to show something else. This is thanks also to the Gates Foundation, others, but it's a very short slide of showing very nice things. Is in the last years alone, HBV, so that's hepatitis B virus and HIV viruses. There has been hepatitis B. There have been vaccinations which have really shot up, and in many countries you have very good, India is famous for it, also Brazil was famous for it, for very good vaccination programs, which really saved lots of lives. Polio, measles, all of that have been increased. The other problem we could go into, I don't think I have the time, but go to undernutrition, which is the other big global health, public health problem. And you can see the different fields: food technology, health promotion, nutrition intervention, clinical nutrition, all of epidemiology here, surveillance and basic science, all of them trying to address it, and how much they address the different aspects. But essentially, we must concede that the undernutrition has to some extent been reduced. Breastfeeding has been addressed, but really it's been quite a failure to weed out undernutrition more successfully. And that has many political reasons. It has reasons of infrastructure, it has reasons of farming, it has reasons of access to markets, and you name it. But essentially, public health has not been able to provide recipes to, fight undernutrition more successfully. And then the last thing, again, I changed it just this morning because, again, I'm always, how can I say, hit by the opioid crisis. I think it's the big failure of public health. Why is it a failure of public health? Because we did not see it coming. We haven't provided prevention measures. We haven't provided early public health pressure. We came too late. What are we talking about? We're talking about a crisis here in 2013. It started on of synthetic opioids. We're talking about opioids which are typically prescribed by doctors, so fentanyl and tramadol and oxycodone, which are really on the market big time in the 2010s and led to opioid addiction, which then kicked in and people wanted more heroin, they wanted other opioids, and then after that, they died. So here you look at some numbers, it's too many to look at, but 50,000 heroin new addicts a year. We have 750,000 addicts. We have so many million prescriptions of opioids still in the US, 10 million per year. So, and we have 70,000 deaths. So if you look this up, this should amount 70,000 from drug overdose. But we also have heroin overdose and other overdoses. It amounts to enormous numbers. And why I think it's a failure? Because the FDA, that's the that's the drug authority of the US, failed to regulate it, didn't really intervene. The companies denied the addiction risk, sorry for the typo here. And there was aggressive marketing and incentive to doctors. Essentially, you could say the companies were, I would call it, criminal. You can also say that the medical profession didn't react, they didn't organize, they took no action. Public health scientists largely overlooked this. If anything, this whole death by despair was raised by economists who looked at the simple mortality data. And then we never saw this combination, this interrelation of illegal and natural opioids that was overlooked completely. So you see that, with all the money in public health, with all the schools of public health, some topics sort of, got largely overlooked. There was no programs, nothing much. Only now, 10 years nearly later, are we trying to rein it in. Okay, I want to end just to tell you what other cool topics could we have talked us. We could have spent time on racial inequality. We could have said that neuroscience, I'm just teasing Lewis here, who organized this talk, I think there's not much to be gained from neuroscience for public health. Discuss that with somebody else. Access to healthcare is always a problem. Genetics in the future, that will be a big changer for public health. You will all have one day your genetic variants measured to predict disease. Physical exercise, I just mentioned passing. And there's more successes, like where dementia is on the decline, believe it or not, in sort of numbers per age, not in absolute numbers because we're getting older, but in numbers per age, and cancer too. So there's quite a bit of success. With that, I'll end the talk and take questions. Thank you very much.
Yeah, so I can just quickly say one thing. So thanks a million, Henning. It was a great talk, super interesting. And I would like to open the kind of discussion round with the first question. It's not directly linked to the topics there, well, partially, I guess.
I can also close the presentation. No?
Yeah, that doesn't matter. It's more about, there's a trend in tracking everything you do, whether it be Apple Watches or these kind of Oura rings where you can track your sleep, your habits. You track what you eat, and they kind of tell you how fit you are and how good you're doing. Is there any value in that, or is it just basically being restricting oneself in order to try to optimize, but in the end, not really?
Thanks for the question, Lewis. Well, there's two sides here. One is the value for those who own the data and use the data. So let's not forget them. They can use it for not only for marketing, optimizing their product, but also research. So that data is certainly being used. So is the value of you? There have been very little studies showing a real value of regularly using your, Apple Watch or whatever you use to your Fitbit to improve it. I think it's more, it's a classical tool of monitoring and motivating. But you can also use, pen and paper for that and say, I ran, I did 15 minutes a day and put it down. I don't think it's been much else. Sort of these physiological measures are highly imprecise and have not been shown to be of individual value yet. Other than, again, that it motivates people to, stick to a routine. So it's like, like a weighing scale. It helps. The weighing scale doesn't make you much slimmer, but it may help you, not have another dessert that evening because, you're monitoring yourself.
Yeah, thanks. Yeah, I'll actually tell my sister that.
I don't think there's much, the sleep monitoring. No, it doesn't, no. Okay, next question.
Maybe for organizational reasons, I think the smartest idea is like the person who spoke last guides it to the next person. So like that would be the format of today.
Okay, Lennart, but you go.
Okay, I will go now. But first, thank you so much for your talk. It was pretty interesting. And like I have a general question about your opinion on something. I lived in the Nordics, like I studied in Denmark, which is really close to Sweden. Here, everybody's taking supplements, vitamin D, basically, because of the winter. And what do you think as a medical professional on like this mass use of supplements? Like literally every kid is eating them in form of Haribo with vitamin D, for example. What do you think of this mass supplementation? Is there maybe another way, especially to improve the very high depression problem here in the Nordics?
That's a wonderful question. I love it. And I have a strong opinion on that one. There is evidence, very little evidence, but there is some evidence for folic acid during pregnancy, or even as close to conception as possible. There is some evidence for vitamin D in very high risk populations with bone problems. But otherwise, the evidence for many of the vitamins from the randomized clinical trials is negative. What I mean with that is that we've seen beta carotene trials and we've seen vitamin C trials, which led to increased mortality in one case, and the other one was increased cancer. I had actually for many years an exercise in Rotterdam where I had people calculate the number of deaths in clinical investigations due to taking vitamins. There is no evidence that it helps. So I'll tell you it in another way. Our evolution is quite perfect. It's quite perfectionated. There's very little we can take if you're healthy. It's very different if you have symptoms or very high risk. But if you're healthy, to take something and then have a health effect. And for vitamin D, essentially, it is largely outside very extreme populations like Black people in Scandinavia, brown people in Scandinavia. There is very little evidence that anything helps. So I would stay away from it. There's no evidence.
Thank you very much. I think Kaya.
Although it's a habit, but it's highly marketed. You know, it's highly marketed. Like, you know, you could, but there's no evidence to take vitamin C if you're healthy. Perhaps if you have a very, very poor diet, there is something to be said. But then, you know, you must really have a poor diet. So, you know, given the Mediterranean evidence, it's much better because not only because of vitamins, because of other things, to eat a bit of fruit.
Thank you very much.
Okay, next question. But you have to pass on now. In your own scheme, you have to pass on.
Kaya? I think she left
Sorry,
us. Oh.
sorry, I was muted myself. On the mental health slide, you showed us the graph with the increased cases of depression among adolescents. And I was wondering, is it really the amount of cases going up? I mean, probably. Or is it that due to the destigmatization of the whole problem and of mental health problems in general, that those cases that can be monitored have increased? So I was wondering, what do you think is the percentage of people that actually develop depression, like the amount of people that develop depression now? Or do you think it's more the increasing cases is due to the destigmatization?
I wouldn't call it yeah, I know what you mean. I think it's, again, a very insightful question. Let me just say, you're asking the question, is depression really getting more? Or is depression more because people admit it more? That's a bit of a philosophical question, because if you don't admit the depression to yourself, I don't know, where does it end? Is that then no depression? You know, if you say, I'm fine, to yourself, you know, because we have little evidence to believe they are not answering honest. So they're always answering honest what they think. There's no evidence to think that. What we essentially see, and I can illustrate that best with the boys and talking about anxiety. It's essentially, I have argued publicly that it is an achievement of our society to enable boys to talk about their anxieties. That means they do experience them. They now face real anxieties. And the price of that is, of course, that they have more anxieties. I'm not trivializing their anxieties, but it's really a sort of novel thing that a 16-year-old man or boy would say, you know, it means he has probably more insight, he is more sensitive, it is a very hard thing. There has been a change, and I think it is, perhaps you're right, related to that destigmatization, that ability to talk over things. It's like sort of, you know, we know that our parents and our grandparents' generation was not able, not willing, not taught to, you know, they came with somatization problems, they came with shoulder pain and nobody could find the reason, but that was essentially their way of showing I'm not well. So it's, I don't know, is perhaps the best answer. It's a bit, it goes together is the other way to try that. Thank you. But brilliant. And there's people, you know, Keyes in Colombia and others, and Colin Shaw in Cardiff are trying to write books about that question. So it's not a trivial one.
So it's also about that people realize their symptoms and now find a word to describing what their symptoms actually are.
Essentially, that's also
okay. Thanks, Lucas. I think it's your turn.
Yes, thank you. So, in your opinion, how big is the impact of sugar consumption on society? How long do you think the problem will accompany us in the future? And in your opinion, what could be done to reduce it?
Sorry, what consumption? I missed that.
Consumption of sugar,
Sugar.
of refined sugar.
Yeah, so that's a game changer in the last years, that we have the insight that sugar is much more of a problem than we thought. And certainly in the US, it depends on the society, but certainly, but we see the obesity epidemic even in countries like India and China, where traditionally much less sugar is consumed. There it's partly because of them eating much, much more meat than in the past. But sugar is, so I can't look in the future. I think there'll be a bit of a pushback against sugar, but it's not something I can predict. Will there be a fashion? Will that be coming? But I think your underlying statement that it is, certainly when we drink it, but also in our food, it is really a problem. That goes without saying. And it's not even just the calories. It seems to be that type of calories, that way to deal with glucose is particularly not good for our body. And certainly this refined sugar. I think we've realized that now. We're seeing slow reductions, but not as fast as I would like to see it. So, I can't look in the future. I think we'll tackle it a bit, but too slow for my liking.
Thank you.
I think most of you should, address it yourselves in your, there's groups that essentially give children very little sugar up to a certain age. And I can tell you it has many effects. One of the effects is that the teeth are much better. Even if you don't care about health, physical health, dental health is a real thing.
Thank you for your answer. It was really interesting to hear a professional opinion on it. I have a second question, which I'd like to ask directly. How big of an issue will mental health illness pose in the next 20 to 30 years in society?
It's not going to go down. It's not going to go down. And what you see is, I've as a personal interest of mine, I'm quite interested in the change of how mental health is perceived in Asia, because what we took 30 years to destigmatize somewhat mental health, they're taking 5, it's going much faster. They're starting now, but they're so quick in addressing it, adapting it, studying it. So it's a fascinating movement. I think, essentially we are much more alert, we're much more aware, we are much more open to discuss it. That means we have more, but we also have more, essentially we're much easier to relate stress into mental health. That's also something essentially we nearly learn, we don't react so much with somatic things. So I think it's not going to be a mental health crisis. I don't think that's really true. I don't think, COVID may have given us a rise, but I don't think there's a mental health crisis. That is overplaying it, but I think it's there to stay. So you'll be surprised that always, you have a lifetime risk of above 30% of developing a mental health disorder, which is severe. And, that means that your baseline risk, and everybody here on the show's baseline risk, is very high. And we will face it much more in the future because it's treatable and it has major implications. So I think it's there to stay, but I don't want to make the impression, I want to say that very clearly, don't be afraid of the big mental health epidemic. That's not, people are quite resilient, and I would even say happy.
Thank you so much. I think the next person was Robert.
Yeah, thanks. I got a question on growing muscles. Like, there are many people who want to grow muscles fast, and they use supplements like creatine, protein powder, or pre-workout, like to hype themselves up when before starting a workout session. And I want to ask if you recommend using these kinds of supplements, or if there are any risks to them.
Yeah, there are risks. So if you go to the fitness studio, which is probably what people who eat that do, otherwise it doesn't really help. There's two things you can do there which make absolute sense. One is to work on your cardiovascular fitness, which is like, running, rowing, or stepping, or whatever. And the other thing is work with the machines that you can also improve your muscles, but work on the way you position yourself, your posture. So, you know, to stand straight, to sit straight. And the other thing is also to improve the range of your movement and muscles, because most of us sit still all day, and you can go to the fitness studio and really sort of expand the range of your movements. Those have been shown, for example, the latter has been shown that if you do that, you have less joint problems later and you have less falls. You know, if you do that in an older age, it really protects against falls. And to some extent, building good muscle, building naturally good muscle will also help you there. It does protect your joints. It does protect you from falls. Now, if you do hypertrophy with supplements, I've not seen any evidence that that is good for your long-term health. I'm not so sure it's so bad, because I've not seen very good evidence how terrible it is. Otherwise, then you use it in, you know, in huge amounts, and, you know, you use testosterone or hormones with it, then it really is bad. But normally, I think it's like a cosmetic thing. You know, you could, you know, I wouldn't do it, and many people wouldn't do it, but I'm not sure it's a big public health risk unless you overdo it. But I wouldn't, you know, essentially, I wouldn't use any of these supplements. There's no gain to be had.
All right, so thanks, but I got a second question about energy drinks. Does consuming these energy drinks cause cardiovascular diseases, like especially at a young age?
So energy drinks. So there's two important ingredients in energy drinks. One is sugar and one is caffeine. The caffeine is essentially a cognitive and physical stimulant, okay? And if you use coffee in moderate doses or caffeine in moderate doses, it will improve your cognitive performance to some extent. And it has some even metabolic advantages. It's not a big problem. The only problem is that if you use energy drinks, you easily overdose it. You get so much caffeine that it's not good. So it's essentially a dose-dependent thing. So people who drink 1 or 2 cups of coffee, you can show that if you're sensitive to coffee, if you like coffee, then it really is good for your concentration, full stop. It's, you know, it's one of the universal doping mechanisms. You know, another doping mechanisms for many people is Ritalin or methylphenidate, that it can, sadly enough, not only prevent or treat ADHD, but even in sort of some of us, it can improve our cognitive performance. So you could, you know, you can use it with some side effects again. But caffeine is actually considered a harmless, if you wish, lifestyle drug. And as that, drinking a bit of energy drink is not a problem. The problem is they put up so much sugar with it that you're essentially drinking something quite unhealthy. But, you know, if you drink it just once in a while to improve your cognitive performance, here we go. We know that if you drink a lot of it, you do have higher cardiovascular risk, and that is mediated largely by diabetes and vascular damage. So, you know, I don't want to make an energy drink into a terrible drug, you know, which is should be forbidden. It's just that, you know, if you drink energy drinks 3 every night to do your night shift, that's really shit. But I don't think that one energy drink and while I have my coffee, that's perfectly, I think, you know, come on.
Right, thank you.
Okay, so it's my turn, I think. So first of all, thank you for your presentation and for your insights. What do you think about school closing to fight spreading COVID in the face of the consequences for many, many students, especially for young students regarding mental health issues? So what do you think?
You know, I avoided that topic on the list of good ideas and good epidemiological insights because I'm not really so sure what I think of that. There's been a bit, if you take my colleagues here at Harvard and I cite them, they think the school closings were largely too far, too long, and too strict. You know, I wouldn't make it a black and white thing. I think if you have a real crisis and it's really bad, you must do everything. But it was too early on the agenda. You see what I mean? It's sort of, you have a last resort, and you know, if you can sort of think, what do we need to close? Because, for example, outside things shouldn't have been closed at all. You know, having bars in the outside is probably not a big issue. And we really were too indiscriminate with some of our closings. That's a bit in hindsight, we know better, but having complicated rules, people didn't like it, but I would have closed schools later, also because of the impact it has on families. So, you have to stay at home with your kids. People couldn't, it has, and because of 2 years has big damage, certainly on the less privileged to where nobody cares about the homework. So I think it was, you could quote me that I think we did it too radical and it was a mistake.
Yeah, okay, I would agree, because many of our students, especially in class 10, got depressions, for example. I don't know any numbers, but it was quite high. Okay, my second question, so regarding dementia, my grandfather died because of dementia, and what are our successes right now in science?
So there's 2 answers to that: the medication and the prevention. The medication has been largely not successful yet. There's been a lot of money in the last 20 years in dementia medication to treat dementia, and all the trials, there has been one which was really debated a lot in America. You must say they were negative. We have not found a drug that you can give somebody with cognitive decline to treat. At the same time, the incidence of dementia, so not the prevalence, means that so many people have dementia, but at a certain age, your chance to get it is going down. So you'll get older and the risk of you having a dementia is 86 is lower than your father's was 86. That's what we see. And why is that? That is largely because of your better vascular health. So vascular problems like stroke, but also other small vessel diseases, is a big risk factor for dementia, actually one of the biggest. And that has been treated actually because of the cardiovascular treatment well, and a side effect of that is partly that dementia goes down. So there is good news, but a lot to be done.
Okay, so thank you very much for your time. Yep.
Who's next?
Okay, so my question is a bit about sleep deprivation. Just in general, like a lot of guys here like dream about in the future like working in some kind of like investment banking for a couple of years, and there's like this certain stigma that you have to sleep for 1 or 2 years, like 4 to 6 hours max every day. And I was wanted to like get your insights about how this really long-term affects the body, and if it can withstand it for 2 years and it's like a hard time but it's fine, or if it's really takes long-term, the body takes long-term damage.
That's a very good, and I don't know, you're asking me on the whole breadth of medicine and public health as if I knew everything. But I'll happily take up this question too. So, okay, there is now more insight that chronic short sleep has physiological and medical consequences. Now, the problem is always, does he or she sleep shortly because he's ill, or does she sleep shortly because of societal pressure or whatever? And that can't always be differentiated. We think that even in high functioning jobs with short sleep, it has some long-term consequences. Now, 4 to 6 hours, and certainly 4. What are the consequences? One is obesity. Another one is a higher risk of cancer, actually has been shown. So they have been associated with very short sleep, but it's not that very strong. The more immediate effect is actually that if you work in a high functioning job, many people will find it actually hard to function optimally with 5 hours of sleep. So it's interesting that some people argue that sleeping 7 hours will make you work more efficient in the day. So not, at least long term. So if your question is, if I do it for 2 years and then move on, I don't think you have any problem at all. Just fight it through and do it like a sort of army service. And I don't think there's any long-term consequences. If you find a job where you have to work 4 hours, 5 hours, like politicians, they're not the most long-living people. So you might want to avoid that. But otherwise, I think if you can balance good functioning with short sleep, and you have a period in your life where that's, be it a small child or be it a job, you're quite robust to that too. I wouldn't be too scared.
Thank you very much.
Go on, next one. Leonard again.
I think it's me. Yeah, you mentioned in your talk malnutrition as a threat for public health, right? In one of the slides. What do you think of alternative methods to treat malnutrition, such as CRISPR-Cas9 or vertical farming? So like modifying, for example, plants or agriculture to treat the problem, or like adding vitamins in regions where they basically only eat rice, for example, like in Southeast Indonesia. Like, do you think that would be, even if we don't know all the consequences, like a fair chance to reduce that risk, which is there?
You know, I'm now going beyond my public health expertise, and I can't really take that question. I have an opinion, but that's a private person's opinion, Leonard. You know, okay. I have my private person. That's like a political opinion. It's not like, you know, I'll give you a private opinion, but really it's not informed by deep public health insight. It's more like, you know, having a wine and cheese debate or beer debate that we can exchange that. I think the way to use genetically modified crops to come together with certain pesticides is the wrong way forward. I'm not so sure that we should not improve our crops with genetically modification in the general sense. I once had one of my neighbors and a good friend. He was in a Dutch vegetable seed making company, and he showed me how the genetic and the traditional modification of plants is actually nearly the same. You know, once you do it in, you know, manipulated by other methods, it was the same. So I'm not so fundamentally against it, but you know, again, I'll pass this question, honestly. We have to stick to public health, otherwise Henning Tiemeier talks about everything, anything. That's a bit embarrassing if I listen to it on YouTube later.
Thank you very much.
Pleasure, thanks. Good question though. But...
Oh, I think it's Kaya's turn now.
Kaya or Jan? Okay.
Yeah, I forgot to unmute myself again. So earlier you talked about that Asia is going to surpass us in mental health awareness and treatment. However, as of today, South Korea, for example, has the highest suicide rates amongst developed countries. So I was wondering on what you base that to make that prediction.
So I don't think they surpass us in mental health. What I meant is they will destigmatize the mental health. So we have a long advantage, a big advantage there against Korea. Korea is one country where, of the industrialized, where it's highly stigmatized. I predict, however, that will change. So Korea is struggling with this. And if you now have eating disorder or even autism in Korea, you're still stigmatized. That is absolutely correct. And that's part of why they have this high pressure on kids. And then that results often untreated in high suicide risk. I wanted to make sure, so I'll modify my statement. I wanted to make sure that I predict, and where do I predict it on is just the grants awarded, the research activities, the public health debates, the Prime Minister one of the ministers, not the Prime Minister, I think, of Singapore admitted a depression. That was a big shock for the Singaporeans because he said, I have depression and we should treat it. And, you know, it has been treated well. And I want to, you know, make sure that in our country, everybody can be treated. That's a change which was 20 years, you know, not, and you see the same, you know, destigmatizing things by politicians is a good indicator of the, you know, other ones is actors. You know, if actors talk about their problems, and they do in the West all the time, they're starting to do that there. That's why I predicted. And you can see, I can see that in, you know, 20 years, I wanted to work in China and the Chinese didn't want a mental health person. Now they are trying to, you know, be the best in mental health research. That does not mean that, so get me right, Korea still stigmatizes mental health dramatically, but they will start addressing it soon, is all I'm saying.
Okay, thank you for clearing that up.
So I'm hopeful, if you wish. I'm very hopeful, but that's, yeah, that's me.
Thank you.
Okay. Is it Jan?
Okay, so since the trend of vegan and vegetarian diet is growing bigger and bigger, what are your thoughts on that, especially regarding that a lot of vitamins, such as vitamin D that we discussed earlier, and iron are missing in that diet, are replaced by, for example, these supplements that we talked about earlier.
Yeah, so I always wanted to study, or was interested to study, the effect of vegetarian on health. Now, you can't study that in the West, because if you study, you can't randomize people. You can't say, you'll become a vegetarian tomorrow, or you become one. That won't work. Nobody will participate in that study, because they'll say, I don't want to become a vegetarian, or I'm already a vegetarian, or whatever. So you cannot randomly assign that. So you have to study that by following people who are vegetarians. But if you take vegetarians in Germany and UK or Netherlands, you'll find that they are health conscious, health interested, doing more sport. They're all young and fit. And so you can't study them, because whom do you compare them with? It does not work, and it's not been done. And there's a good joke in epidemiology, that's the most impossible question to study in Western societies. Now, we went to India to study that, because vegetarian in India is partly religiously determined, and thus it's a family thing, and it's not even tied to socioeconomic status of things. But that's very hard, but that's what we hoped to do. So first, my answer to that is we don't know the effects of vegetarians, but we have good ideas that it is quite healthy. You're saying they miss iron, they do miss vitamin B12 and some things they could get from nuts or so. They do miss some things, correct. First thing to be said to that is, however, if you do a very conscious vegetarian diet, you can eat a vegetarian diet which does not lack these things. And indeed, if you don't manage, then you can indeed supplement some, or they do supplement some, like vitamin B12 and others, sometimes vitamin D too, with pills. I think that makes sense. The theoretical notion is that that's still healthier than eating lots of meat. I don't think that has been shown, for the reasons that it's very hard to study. But there's all reason to assume it's not an unhealthy diet.
Okay, guys. I would ask one question. After that, Hannah will close the discussion. So let's get back to a recent development. You are living in the US, and Roe versus Wade was recently overturned. And what is your opinion on it? And what will be the effects of the public health sector?
You will not believe it. I was on a CBS interview Sunday on that question. And they asked me that too, and I try to shy away from it. I think maternal mortality is not so strong in the US, but let's talk about Roe versus Wade, which essentially is the decision of the Supreme Court to give the states the right to legalize or ban abortion. What does it mean for public health? Let me first start. I think it's largely, not solely, but it's largely a women's rights question. I think it's a women's rights question. So to discuss it as a public health question is fair. It is a public health question, but it's not primarily that. Okay, public health, what it has, two effects. It has three effects. One effect is illegal abortions will go up. So people will do illegal abortions. Now note that illegal abortions today are much easier than they were in the 1970s, because we've got very good medication to send to people so they can buy it, not in the pharmacies, but probably online or in Mexico or in another state, or from friends who spread it. So we have very effective medical abortion, certainly until week 15, they've shown to work brilliantly. And actually, abortion is safer than a childbirth. So if you do it that way, it's safer than childbirth. So I suspect there will be illegal abortion. I suspect there will be surgical illegal abortion, which is much more dangerous. And that will lead to some deaths. Now, we know from the 1970s, there were probably 100 deaths, 150, 200 deaths, whatever they were. Not thousands, but there will be. And I think it'll be much less because other states will offer it because of medical abortion. I can't quantify it, nobody can, because it depends on 20 things, but it'll be some deaths. You know, if you speak to in other terms of opioid crisis and shootings, it's not that many, but that's, I wouldn't like to say that public because it's too many. It's far too many, of course, because they're utterly preventable. The second thing is you'll get children which are born to mothers that are denied abortion, and that has an effect on mothers and children. And it has sort of many, many subtle effects. You know, it has effects like that they will be poor. It has effects that the children, even the children born before that, because many of these mothers have already got 2 children or so, they will have less chances because they're poorer. You can see that there have been studies of showing that, comparing that they'll do less well. There'll actually be things like more domestic violence because another child or a child is a reason to stay in an, you know, often, let's say, an abusive relationship is a reason not to have the child, to try and seek an abortion. If that's denied, it can lead to more violence. So there is all these consequences. You know, fact of the day is that women who have an abortion rarely regret it. They normally know what they're doing, is all what our studies have shown. And you can be for or against abortion, but to deny somebody an abortion is a tricky thing because we know that they really don't want the child and it's a safe procedure. So that is another consequence. And then there are other unintended consequences. The third domain is, you know, what will it affect the other health services if there's no abortion possible? So how will it affect women who should receive an abortion because of medical reasons? Will there be even any services for them, or will they shut down too? You see that in Poland, that the legal abortions are also going down because nobody's going to do it anymore. And the other things, you know, we don't even know if it has even broader consequences, because will the Supreme Court soon say IVF babies that are not implanted, are they also, if they're discarded, are that also a form of abortion? So that would have real repercussions in another public health sector. So I think it has public health, and none of them are, you know, what you would want. I'm very disappointed. More than that, and I'd like to talk about that longer, that now if you do such a, if the states decide to ban abortion, why on earth don't they then invest in sexual education? Why don't they invest in poor families? Why don't they invest in daycare? You know, if you, I don't understand all of this, that this, you know, just to, you know, you leave women terribly alone. You give them a right, and then, you know, you don't even care about the poor families that are denied abortion. So I think the whole mix is essentially has nothing to do with public health. Indeed, it's not good for public health, but it's a women's rights issue.
Thanks, Hannah.
That's it.
Okay, thank you so much for your detailed answers thus far. Is there any other student who would like to ask questions? Last chance now, because otherwise I would go on and ask like the concluding question.
I think there's a black hand, Shark.
Yeah.
Vincent, you go.
Yes, so hi, good evening. My question is, I was listening a lot to podcasts of David Sinclair, and my question is, I think you will know him. Do you think that at one point in time, we are able to reverse biological age, and what effect will it have on public health?
Well, it'll have an effect on public health and society at large, you know, if we all stay young. You know, there's 2 basic concepts of biological aging. One is that it is a process in our body that is continuing. So that essentially, like if you know telomeres, that it's sort of like, you know, the like a biological clock that's running out, so that there's a timer, a biological system, which is timekeeping, and with so many cell divisions, we're run out of steam. That is one concept. It's not completely at odds with the other, but it's sort of one. The other concept essentially is much more that aging is the accumulation of damage. So essentially, there is big and small damage on the cellular level, on a subcellular level, and on a big level every day. by a bit of blood pressure, by drinking, by just, wear and tear. Now, I am a bit more of the opinion of the latter. So I think there's good evidence to think that we age because we just, our system doesn't repair or damage, and we have stress, and that makes, it's sort of, if I look at if you look at your own organs, the easy one to watch is the teeth. You really can see the wear and tear with age. I don't believe that there is a clock in my teeth that sort of makes them run down. I think it's just, use and abuse of my teeth. So if that's the case, Sinclair is wrong, because that can't be easily reversed, because it's just a function of being alive. He hopes that epigenetics mechanisms can be reversed. I do think there will be progress, however. So if you believe it's a combination of the two, then interventions in the first can slow it. And it'll be one of the mechanisms that we get a bit older, because I think our age will increase. But I do think there is a bit of a limit too. So I'm not sure we'll all get 150, and certainly not in my lifetime. And the rest, I don't care too much.
Thanks a lot.
Last question, Hannah, then we'll finish off.
Thank you so much. So concluding question for today is, if you were the health minister of Germany or the US, what would you change first?
Oh God, what would I change first? I don't have a good answer to that one. I don't know. Of all the topics we raised, I would do several measures. One measure is mentioned by one of the students. I would address sugar. I would probably tax it, and certainly if it's in, in soups and stuff. I would tax it in sweets and in things. I think that's the case. That's one measure, I think. It's been tried by Scandinavian countries. It's been tried by Hungary, of all places. I think the UK have thought it. And I would really try to force sugar out of some of products. I think it's actually good. I think we could do more for mental health. And that is prevention programs, which I mentioned, sort of bullying things. And something we haven't mentioned, I would experiment with the living built environment for, because I believe we could do better environments for our, to address how old people or young people live. So I would think that can be done a lot. That's a very private issue. So I think, if you think of the congestion of cities, but also I think we should invest very carefully in how we build our cities, also under the aspect of health. So I would force my my colleague from the building ministry, which we now, Ministry of Built Environment, to build health. Those are three things that come to my mind. And the other thing is, perhaps one more, I would do much more randomized trials of social policy. So if you think of ongoing discussions, how to treat immigration, even how to treat social services, how to do those things, I think we would need evidence often from randomized trials. And I would be as radical to sort of say, let's give half the people who came as refugees or whatever, let's give them a status and see how they integrate, and evaluate that a few years later. I think we need much more evidence. So that essentially I would take the public health aspect. So this is not as a Minister of Health, but more like a Minister of the Interior. But I think we need much more, we need a radical, this randomized trials of policy, which very few have been done. So I know you might know that in Finland, they're doing something like that with a basic income, which you can be a fan of or not be a fan of, but why not just try it in a randomized way? It's unfair for some get it, some don't get it, but then at least we know for everybody later.
Great.
Thank you so much.
Okay.
Thank you so much.
Pleasure.
Tiemeier, for taking the time with us. It was 1.5 hours. It felt like a breeze. It was very great. Yeah. Also, a huge thank you to Louis for getting us in touch with Professor Tiemeier. And I hope that everybody enjoyed it. You can go clap in the chat for Professor Tiemeier. And yeah, very huge thank you from the team. And yeah, thank you for taking the time out of your day for us.
Pleasure. Good luck, boys.
Thank you so much for the
all of you.
insight.